Okay, so I think we can go ahead and get started. Thank you so much, everyone who has joined us in real time today. We will also be recording this webinar, though, for those who were not able to join us to watch afterwards. We are really excited today to present on some hot off the press, if you will, results of the HOMR project, which is a project that was funded by a few sources, but really catalyzed by funding from Health Canada and the Healthcare Policy and Strategies program. And so we're happy today to have this webinar with the PCPCRC to share results of this project. And with that very short, very quick introduction, because the intro is the boring part of today's webinar, I will hand it over to Dr. James Downar to start the presentation and share his screen.
Thanks, Julie, and thank you all for joining us today. Some fun results to share with you today. If at some point, my video seems to be skipping on my end, and it's not the best Wi-Fi here sometimes. So if you're having trouble, please do flag or just unmute yourself and tell me to go over some stuff again. I'm not sure why this is happening. Okay, I will share. All righty. Can y'all see that?
There's just a bit of a delay. There we go. Okay, perfect.
Excellent. And I'll use my little laser pointer. Okay, thank you very much again for joining. I'll jump right into it so that we have time for questions. And I apologize for those of you who have heard me talk on this before, but I promise you there is some new data at the end that no one's seen yet. So just try to smile politely while I'm giving you the earlier part of this presentation that you may have seen before. In palliative care, one of the biggest challenges we have is the reliable identification prospectively of people who might benefit from a palliative approach. Now, process of early identification in general, if we're doing it in the ideal way, would look something like this. Like you'd start off with the step of identification, where you identify people who may be at risk of having unmet palliative needs or you think might benefit from palliative care at that point in their illness. You go on to assess those specific needs, right? So to identify what those unmet needs actually are and obviously within their preferences. And then you move on to develop a customized care plan and manage those needs on an ongoing basis, right? So that sort of paradigm of identify, assess, plan, and manage is core to palliative care and a really important sort of routinizing and improving that process of early identification of unmet needs is a key part of improving palliative care delivery in our system. But there are a lot of challenges with the idea of identifying people when it's early, right? So there is clearly the notion that there is something that is too early, right? This Goldilocks phenomenon. So if you get palliative care from the very start of life, when they're still, sort of in the nursery, they probably haven't got all their palliative needs fully developed at that point. Probably advanced care planning is not going to be a very high yield exercise. You want it somewhere, of course, along the lines in the course of disease management. You can see this bow tie model from Pippa Hawley showing how the two may overlap. But sort of when do you do this screening process? When do you start to routinely identify whether somebody has unmet palliative needs, right? So obviously there's too late for sure, but there definitely is such a thing as too early, and that's been written about many times. One of the things that we're very good at doing, and this is from Danielle Kane and sort of Piet Hein poem, timing toast. There's an art to knowing when, never try to guess. Toast until it smokes, and then 20 seconds less. One of the things we do a lot in palliative care is we wait till people are dead, and then we go around, then we do a sort of M&M rounds where we say they died badly, and we really, all of us should have done a better job. And we sort of, say that, gosh, we really should have done something 2 weeks ago or 2 months ago or whatever, which is, possibly true, but definitely unhelpful, in the sense that what you really want to do is have a system in place where you're identifying people prospectively and identifying those needs prospectively. Telling people that they did a bad job, right, is like walking into a room full of smoke and saying, I think you burned the toast. Not helpful. Timely identification of unmet needs is also, like, conceptually, if you think about what an ideal process might look like, right? You want something that's going to be fairly accurate for identifying people with these unmet needs in a timely way, right? You don't want to be approaching everybody and trying to address unmet needs in literally everybody. Having false positives, there is a cost to false positives. We have limited time and energy. We have limited individuals who can do this. So that would be a poor allocation of limited resources if we're just scattering them to look at everybody. This sort of palliative care for everyone all the time is, I think, a bit naive. And not a good use of our resources. People get to the point of alert fatigue, of course, and then they just stop responding. But of course, you don't want to wait too late, and you don't want to limit it too much, because then you're going to get a lot of false negatives. You're going to have a lot of untreated suffering out in the world, so that's bad too. So finding that middle path between false positives and false negatives. You don't want to make something provider dependent. So one of the core lessons from provider dependent processes like the surprise question are that when you try to roll it out over large populations, you get low uptake. People just don't do it. And that's a problem. Like, people are busy. People have lots of important or sometimes just urgent things to think about. So the less urgent but also important things always get put to the wayside, and that's a problem, right? So having things that rely on humans to remember to do them all the time, that's a very unreliable process. The ceiling will be low. And you also want to try to not have processes that will involve a dramatic change in human workflow. Anything that involves people doing things very differently than how they're already doing them is probably doomed to failure. So using routinely collective administrative data, using a big data approach, that might be a really good way to start to look at timely identification. So one of the tools that got developed, or a mortality predictive model that was developed here in Canada by Carl Van Walraven, actually here in Ottawa, was the HOMR tool, so the Hospital One-year Mortality Risk tool. So this combines 12 data fields in order to be able to risk stratify. It comes up with a sort of score, a HOMR score here, you can see it on the x-axis, that corresponds to mortality risk. And in sort of internal derivation, but also external validation and validation in other geographies, was actually found to be very, very accurate for discriminating between mortality risk within a year, those who will die and those who will not. So that was quite an impressive result for Carl's work. And then we initially took that HOMR score because it relies upon actually having discharge information available to run. So we were trying to develop a modified version of it that could be run at the time of admission to try to help us identify patients in a hospital who might be at elevated risk of death in the coming year, for example, as a way of identifying this high-risk population that we would want to then go off and screen. And so we were able to find that mHOMR and something that Carl subsequently invented that was called HOMR Now, with these models that would quite accurately predict mortality in the coming year, and that could be entirely integrated into an electronic medical record and be used in real time to identify patients as they move forward. So this is, I don't want us to spend too much time here, but just to show the three different versions of HOMR that can be used. And you can see that of the data points, some of them are really just common sort of administrative data points, age and sex, admitting service, whoever admits them, whether it's a readmission, how many times they've come to the emergency department in the past 12 months, how many times they've come in by ambulance, where they come from. Is it a home? Is it a long-term care facility? Is it a chronic care facility? And then did they go straight to the intensive care unit or not? And then in the HOMR Now, you can see they actually were able to integrate a laboratory-based result, so the LAPS score. Because most of the models don't actually even include acute clinical data. It's just who, retrospective information and who admitted you to hospital. And you can see you get very, very high C statistics. For those of you not familiar, a C statistic shows the accuracy of a test for discriminating between outcomes. So a coin flip, the lowest possible score is 0.5, that's a coin flip. The highest possible score would be 1.0. So seeing scores of 0.9 and above, this is a very, very accurate tools. These are the kind of things that you don't see very frequently in medicine. So we started about doing some quality work where we were starting to initially pilot the tool to see if we could be using it clinically in the clinical environment, and then to potentially drive care and change care that we're providing to patients. After some initial pilot work and working with different stakeholders, we were trying to settle on where the threshold would be, because HOMR gives you a score. And then you have to decide above what score, what's your threshold for flagging somebody as HOMR positive, as it were, versus HOMR negative. And we were initially trying to find the best combination of sensitivity and specificity, which turned out to be the wrong approach. Probably the smart thing to do for all of these is actually to think, what can the receptor handle? What is the workload? What is the bandwidth capacity of the person receiving the alerts? Because if you send them too many alerts, they're just going to get ignored. So in fact, a relatively small number of alerts, therefore very specific but not very sensitive threshold became important. So a very good positive likelihood ratio of 6. Very good at ruling in somebody who's likely to be dying in the next year. And you can see it flagged a relatively small proportion of admissions, most of whom survived to hospital discharge. That's important because what you don't want to do is develop a tool that tells you someone's going to die hours before they die. You want to get it earlier, when you're actually able to influence and perhaps change the trajectory of their care in a meaningful, timely way. So the fact that most of these people may be dying in a year, but they didn't die on this admission, that's super important. We learned a lot about how to notify people. Don't use email was the big lesson. And patients were very supportive of the project. This gives you some idea of who the tool is actually identifying, right? So this brings up another key point about how you use HOMR and prospective tools. Because we as palliative care providers, but physicians in general and nurses in general, are actually pretty good at picking up some populations as they approach end of life. So cancer, for example, we're actually quite good at picking up and spontaneously acting on and talking to people with advanced cancer in the final months of life. Where we're not so good and where palliative care tends to be far less involved is in patients with dying on a frailty trajectory or patients with organ failure. And so having a tool that is strong in areas where we are not strong is actually really vital. Having a tool that just happens to mimic our strengths and weaknesses is not going to be as useful. So what's interesting here is that most of the people identified by HOMR are on a frailty or organ failure trajectory. So then on the y-axis, you see here, this is the proportion that had an unmet palliative need. So when we flagged these people, somebody went in and screened them with an ESAS and with an advanced care planning engagement question. So if any of their ESAS scores were above 6, or if they indicated a readiness or willingness to talk to physicians about the care they would want at a future time where they may not be able to speak for themselves, that was considered an unmet need. And you'll see that the vast majority, regardless of trajectory, had one or more unmet palliative needs in that context. So our next step was then to go on to this project, which is to scale the implementation up to multiple hospitals across the province, and then try to evaluate whether the tool would improve assessment, identification of unmet needs, and possibly the end-of-life care. The project itself was just about the tool, though. We didn't actually mandate that anyone do anything in response to this. We were just notifying teams and seeing what actions they took. And then obviously we looked at some implementation factors as well. We initially had settled on about 10 or 12 hospitals, and then COVID happened. We lost a couple of participants, picked up others, and we ended up getting data from 8 hospitals. So this was looking at all newly admitted patients to participating hospital units who got screened with HOMR. We did an implementation that was tailored. We did a tailored implementation process at all the sites. In fact, some hospitals had their own threshold, but usually at the unit level, things got implemented at that level. We did a needs assessment. We integrated with their EMR. We did a go live, and then we did integrated learning. And then, of course, for anybody flagged, we asked somebody on the team, could be the nurse, could be a champion, could be anyone, to do an ESAS with them, and then what was initially the 4-item advanced care planning readiness tool, but just ultimately just narrowed it to the one single question about whether they were ready to talk to a physician about their future care. And again, the team was prompted to respond to it, but not necessarily told what to do in terms of calling palliative care or whatever. This looked different. This had different appearance at different hospitals, but this just gives you some idea in an Epic hospital what this looked like. So this was a nurse prompt initially that if HOMR flagged, the nurse for that day would be prompted to screen them with ESAS and with the advanced care planning questionnaire. So they were given some wording and what to say. Because you're ill in a hospital, we'd like to ask you some questions about your symptoms and about planning for what is ahead with your illness. Is that okay? Some nurses were uncomfortable because they didn't know how to introduce the topic, so we added this sort of verbiage for them. And you can see they can actually just enter it in their computer just at the bedside as they're asking the questions about ESAS and advanced care planning. And then that information would then get bundled into an alert that would go to the medical team, and the medical team then would get an indicator saying that this person, has got an elevated risk of mortality in the coming year, and they have unmet needs such as the following. So, are they ready to talk about advanced care planning, and what were the scores of their symptom assessment, so that the person's getting a notification is actually actionable, like they know specific problems that this person would like help with. And they know if they go to talk to this person that they're not going to potentially get a very angry or scared response, that this person's already expressed essentially a willingness to talk about these things. We were able to put in a link to the serious illness conversation. It's already embedded in Epic, but obviously other resources could be connected as well. And what we did was we did a pre-post assessment at all the 8 hospitals. So for 6 to 12 months prior to implementation, we ran HOMR silently in the background, where it was just flagging people at elevated risk of death, and we would be sort of auditing a chart for one person every other day for 6 to 12 months. Then we flick the go switch, all of a sudden the alerts start going to the team, and then we just did the same assessment of those charts, post versus pre. As you can see, the pre-period crossed into COVID. The post-period was all COVID. So unfortunately, that delayed what should have been a 1.5-year project to about 5 years. But we got some really cool results. And as you can see, so this is the cohort. It's preliminary, so I can give you some of the data, not all of it. These are patients who are fairly generally older, even for a hospital population, roughly half female, half male, about 1,000 in each cohort pre and post. They come predominantly from lower income quintile neighborhoods, which is typical for what you would see for people with advanced and chronic illnesses. That's quite well recognized. In terms of frailty score, it was a fairly moderate frailty score. In terms of people with dementia, about 1/3 of the cohort had dementia. And as you can see, similar to the pilot work, the majority of patients have frailty and organ failure, relatively smaller proportion with terminal illness. So notably, some of the things that stood out from our results. So again, this column you're seeing the percentages from the pre-notifications, and this is from the post-notification or during the notification period here. And you can see that of those completing a documented ESAS assessment. Oh, sorry, did somebody have a question? No, okay. You see that actually we were able to get about half the people with a flag got actually screened with ESAS, which is a very impressive result. We're not expecting 100%. That's a really, really good number. We're very happy with that. In terms of those presenting with an ESAS score, 1 or more ESAS scores over in the severe range, you actually saw quite a high number. So like half of those who got screened had a severe a score in the severe range for 1 or more symptoms. And again, these are largely people who would not have been, I think, noticed or documented to have had that severe symptom had they not been screened. And again, about half got the advanced care planning tool question asked, were they ready to talk to a physician about their advanced care planning or their care planning? And you can see that a large proportion were ready, were ready to talk about it, and a very, very small number refused, only about 13 out of the 500 who were asked. So again, you're very likely to get a willing person to ask you, even if it was just a computer that identified you. So in terms of clinical outcomes, here's where it gets quite interesting. So you can see the mortality rate in a hospital during the index admission was about 16-17%, and that didn't change pre versus post. But what did change was where they died. So in the notification era, in the notification period, a far lower proportion died in acute care, and much larger proportion died in what was identified as a palliative bed, either transferred to a hospice or to a palliative care unit bed somewhere. So that was quite a significant change. Smaller and less common events like intubation and CPR, you can see there was a non-significant reduction in intubations. Unfortunately, it was such small numbers, but you can see it was almost cut in half. So could be quite an important change, although not statistically significant. What was also interesting is there's CHI encodes things called healthcare or hospital harms, and they have different categories of them. So one of them would be medication or laboratory-associated harms, and that drops significantly. They also have healthcare-associated infections, which dropped, although not significantly. But if you follow them up, any hospital harm in the 1 year following that, both significantly reduced. So that's quite interesting to see that perhaps as a result of this notification, that people were less prone to getting bad outcomes associated with being in a hospital. So aspiration pneumonia being an infectious event, and then laboratory or volume related events being the other abnormality that was identified. And that was despite no actual change in mortality, or no significant change in mortality. There was a slight but significant increase in the use of palliative care consultation, by about 5% increase, right? So not a huge amount. So it certainly wasn't just the case that the team was just phoning palliative care and getting them to take care of the problems. You can see that post-discharge, in terms of getting palliative home care, that did not go up. And again, we didn't mandate anything from a palliative care standpoint, so things post-discharge, you wouldn't necessarily expect them to change, although home physicians, non-significant increase. ICU admissions in the year following discharge, hospital readmissions and emerge visits, all of them sort of generally trending in the right direction, but none of them reaching significance. Hospital length of stay did go up. Now, mind you, a lot of that may have been due to COVID and home care related issues, but the cost of care did go down by $200 a day. So quite a significant change there, just to look at that. So yeah, in conclusion, I think what we're seeing here is that in terms of fulfilling the role of the early identification, it did seem that HOMR is actually pretty good at flagging people who may have unmet palliative needs and driving assessment of those needs, and perhaps a signal suggesting some changes in planning and management, although we didn't actually mandate any changes in planning and management. We were just bringing things to the attention of the admitting team. We did a lot of implementation data collection as well, just to see how things went. And what were some factors associated with successful and less successful implementation across the hospitals. Again, generally speaking, most interventions don't always translate into practice. Sometimes you're trying to look at barriers and facilitators, and there's a CFR typology. They have sort of standard domains that they look for. And then we did 30 CFR interviews with people across 8 sites, including managers, educators, nurses, physicians, social workers, and information system staff. So not surprisingly, probably the biggest barrier, unfortunately, was the COVID-19 pandemic. We may have seen even better results than this had there not been for the COVID pandemic, because people just didn't have a lot of appetite for new interventions. But we did what we could. I mean, the pandemic wasn't my idea. I'm just saying. Obviously, with increased workloads, people are hesitant sometimes to take on new things, right? So the idea that you're selling them, the idea that if you do this work now, you will have less work to do later. And if all of us routinely do this work early and in a timely way, ultimately patients will be better off for it, and you'll probably have to do less putting out of fires in the middle of the night and after hours, which is quite stressful. And again, if you can sell that vision to people, if they see that to be true, then they'll do it. And if they don't see that to be true, then they won't do it. Patient demographics, right? So obviously some people, sometimes there have been a lot of writing studies on cultural issues and how willing people are to engage around palliative care and palliative care needs around advanced care planning. And so in some cases, like even if HOMR tells you to do something, you're not going to do it because you don't feel like it's necessarily something that's going to be well received, or it gets pushed back on. People are just unwilling to participate. Although the rates of unwillingness to participate were really low, just to be clear. Facilitators, obviously a motivated workplace culture, having a good champion like leadership on the nursing boards, and having champions among the clinical teams was a vital factor. So if you get good people leading it, people will follow. And there was a lot of desire to innovate. Like some people were genuinely proud to be part of a project that they saw as innovative and meant to address a need that they were perceiving to be present and important. That's a really key factor. Shout out to the team at Princess Margaret. So they used this as well, and they've been using this to trigger referrals to palliative care. So again, not what we had initially envisaged at our project, but they did this where they involved it just as for inpatients on the on the oncology services at PMH to drive referrals to palliative care, and they found that it was would have been helpful to use it to identify people with unmet needs that flew beneath the radar. So in conclusion, use of the mHOMR or HOMR tool is effective for improving documentation of palliative needs and increasing the proportion of patients who have goals of care discussions. It can be complementary to physician judgment, and there's some suggestion that it might actually improve outcomes in terms of dying patients dying in more appropriate locations, and potentially reduction in hospital harms. So again, that's that sort of speculative stuff. We're trying to unpack a little bit the link between how that might have come out, and is it we can look at maybe individuals in whom more was done. Did that seem to be linked to it? Because the problem with a before-after design, even if we've done it in a prospective way, they can still be confounded by secular trends. So I don't think it's likely that the hospitals were getting dramatically safer over that period of time, or that people were getting dramatically sent to palliative care much more often, to palliative care beds more often over that time. I think actually the opposite was probably true. But again, it was what it was. And so we're hoping that these findings will enable future hospitals to use the tool proactively for successful implementation. And we're already in the process of national and international scale and spread. We've had interest in partnerships developing in British Columbia, Nova Scotia, other parts of Ontario, of course. Quebec has expressed some interest. We've had partnerships and we've gone down the pathway a little bit with some NHS trusts. A hospital in France and Italy. We're hoping to get an invitation to meet with them. Still waiting, but it's definitely going to happen. Ultimately, just a big thanks to all of our funders. So Health Canada, the Healthcare Policy and Strategies Program, that contributed to this project. CIHR, who funded a lot of the implementation work. CFN were early supporters of our pilot project and very helpful in terms of giving us some bridge funding to get to the next level. And Healthcare Excellence Canada, that also gave us some programmatic funding. Super supportive. Thank you. And of course, CABI, who were involved in our work as well from some of their dementia work. Really vital support at a vital time, and we're really proud to be able to show these results, hopefully to reward their funding and of course their patience, because this project was delayed so often. So a big thanks to all of you, of course, for paying attention. And if I went too quickly and you want to go back and look over some of this stuff, there's a couple of videos here in the HOMR Explainer video, which has all about how HOMR works, along with a very peppy and upbeat corporate jingle in the background, which you will all find inspiring, as I did. So thank you very much for your attention, and I'm happy to take any questions. Okay, thank you so much. Okay, Rhiannon.
Hi, James. Thank
Hiya.
you for the presentation. I had a question regarding some of your findings. So, my understanding of the difference between pre and post is that post there was an alert to the medical team, but otherwise the intervention remained the same. I noticed in your table that a higher
Sorry, there was no intervention in the pre-period. So we were like, HOMR was just silently running in the background, identifying patients so that we would have a sort of apples to apples comparison of similar patients pre and post. And there was no intervention whatsoever in the pre-period. The post-period was when the intervention took place, where we were starting to send alerts, just to clarify.
And when did the ESAS happen? Just post?
So the ESAS, ESAS can happen. Anyone can use an ESAS, and there was a small number, like about 5 or 6%, who were getting screened with ESAS forms, or at least one sort of component of ESAS in the pre. But the only thing we mandated in the intervention was when a notice came to the bedside team or to whoever was leading this, that all we were asking them to do was to use an ESAS to screen them for severe symptoms as an unmet need, and to ask them whether they were ready to talk to a physician about the care that they would want to receive in future when they were seriously ill. So that was the only thing we mandated, was just those two screening activities.
Okay. Then that might relate to my question. There's a large difference in proportion of individuals that were ready to have that advanced care planning conversation in your table, post versus pre. What do you think the difference?
Oh, well, so I mean, in the pre, we actually have detailed data on how often there actually was a documented goals of care discussion. I didn't present that data, but that went up quite dramatically as well. But I think the issue there was that if you don't ask if they're ready, then you won't know if they're ready or not, right? So only very few people were asked if they were ready in the pre-period, there would have been documented some aspect, and we were very loose in how we interpreted goals of care discussions. Like we said, anything, like basically basically if you wrote the letters D, N, and R, we gave you credit for that. But I mean, in the post period, of course, they tended to be much more detailed beyond simply a CPR order to actually talk about goals and values. So it's like the number went up, I think, by about 25%. Absolutely, if I got that right, Julie, just correct me if I'm wrong. Went up by about 25% overall. So any discussion whatsoever went up by about 25%. But any discussion beyond just CPR order went up, like I think about 40% or something, absolute number. It was in that range, if that's helpful. So yeah, to your point, that specific outcome of were they ready to talk about advanced care planning? That was obviously not a tool that was routinely in use before, and we were driving it to see if it would be done to prompt potentially an intervention by the team, and it seemed to do that. But what we also wanted to get was how often were people like unwilling or just did not want to reject it, the discussion, and it was like 1%. Is that hopefully that answers your question, Ryan? Thanks. Kate.
Hi, thank you so much for your presentation. This is my first time hearing anything about this big project, so it seems very exciting to me. And I was just curious if there's any interest in adapting or validating the tool for pediatric populations.
Yeah, so that's a great question, Kate. And I mean, there's obviously interest for sure. My intuition would be that this tool, I don't think you could use this tool to predict pediatric mortality because it depends a lot on things like age and like what your like morbidities and comorbidities, Charlson score, how many times, like, do you live in long-term care, et cetera. Like that's heavily what drives this. Like a large component of this model is simply driven by age. And so you couldn't, I don't think, even use a slight adaptation of this, even slightly in the pediatric world. However, what you want, I mean, again, and also HOMR is just as a concept, right? Like the sort of black box algorithm of flagging who's at elevated risk. Like any tool that would identify somebody as being at elevated risk, so RESPECT would be a great example, and there are others out there. Tools that can help flag who's at elevated risk. And my suspicion would be you could probably develop such a tool and validate it using ICES data in Ontario based on a lot of data. Now, the challenge, of course, is that there's just far more adult data than there is pediatric data. Certainly mortality, thank God, among pediatric populations is much, much lower. So to get a good model, you need lots of people and you need a good chunk of them to die in order to validate a model. So unfortunately, all of that stuff works against pediatrics. And I know that, like, I've looked at some of the metrics around other models that have been developed, and they're not great. But my guess is that you could probably get a pretty good one going if you wanted to look into this in Peds world.
I'd definitely be interested in it. Thank you so much.
Yeah. I'd be happy to connect you with somebody if you wanted to try to validate that. Riley.
Hello, can you hear me?
I can.
Awesome. Yeah, I was just kind of curious about kind of like the feature selection process for the score. I might have missed it earlier, but I was curious about like patient public engagement or involvement in that process and just kind of like how that looks, just because that's kind of tangential to my thesis. And I found, there's not a lot of patient and public involvement in the area, but I think palliative care is, special for that.
So in terms of developing the actual tool itself, like the algorithm, there was no public involvement. It's just big data, fed into a computer. But the process, our programs, our HOMR project has since I'd say very early on, like one of our biggest things at the start of the feasibility questionnaire was we did a qualitative study driven by HOMR. We actually used HOMR to identify people that we would then go and interview. And it stands as my personal record for the fastest qualitative study I've ever done. It took 5 days to get 27 or something interviews done because we just used HOMR and we just went and talked to them. And you showed up with a list. And my research person doing the study, she actually took longer to get into work and home from work than it took her to do the interviews. And it was just remarkably efficient. And that was really sort of a cue for me that was really helpful. And what, of course, we found in that qualitative study was like, and we're asking, like, what do you think of this? Like, what do you think of a computer program that would be silently flagging mortality risk for somebody and telling doctors, would you be worried that you might get treated differently or badly or substandard? That was really not endorsed by anybody. They were really positive about this. There was some like, well, maybe, but there was much more like anything that will get the doctor to talk to me is a good thing. And then when we went and did the implementation study with all the various different sites, many that we had patient and family partners included in the project, and we also had many of the sites in implementation. They had like a patient family advisory committee level, and it was funny because like the first hospitals where we went to do this, the patients were like outraged that you weren't doing this for everyone. Like, why would you only do this for people who are HOMR positive? You should do this for everybody. And it was like, the consistent theme from patients and family and advisors was yes, but more. Like their disappointment was it was so limited. And again, like can't please everybody, but the end of the day, we found that really telling. I think we are often in healthcare concerned about things on behalf of patients, but those fears don't always align with what the patients themselves fear and what their priorities are. I think that generally speaking, this, as with most other things, patients are generally much further ahead on this than we are. And I mean, we've all had bad experiences, right? Where we go into a room and the patient blows up, right? Like the patient gets really upset that they're being asked this, they respond very poorly. And when you're a resident or a trainee, that's a very traumatic experience, right? Like you remember being yelled at or causing somebody to cry. And none of us went into medicine to get yelled at or cause people to cry. So it hurts. And then you sort of remember that. And so it's this recall bias that holds you back. But when you look at it, right, you can see that actually, and these numbers pan out in a lot of studies, that somewhere between 25 and 50% of people find these conversations really helpful, and about 1 to 2% find them really stressful. And so again, you're always going to get, it's like any drug that's effective always still has a tiny proportion where it'll cause a side effect, but you don't just stop doing it because there's a side effect. Like you look at the risk benefit balance there. And on these grounds, right, those goals of care conversations tilt very much to the positive, but you are occasionally going to step on a landmine. There's no question.
Awesome, thank you.
Can't stop it. Is that helpful, Riley?
Yeah, and I guess I just had one more question, if that's okay.
Yeah, go for it.
Just gonna be pretty quick. What kind of like model development did they use? Was it more like machine learning, or was it more like logistic regression?
Yeah, it's forward and backward logistic regression.
Okay.
I'm going to use a bunch of words that I don't actually understand. No, I'm kidding. But what I think these are really complicated models when they're built. So there's a lot of these sort of interactive variables and stuff like that. There's cubic splines involved, I'm sure. And ultimately, the forward and backward process of model development, but then of course you derive and then you validate. And I would refer you to the CMAJ paper from 2015 where he originally did this to sort of show how the process by which it was done, because it was I think they go over it in really good detail, if I can refer you to.
Sounds good. Thank you.
Big shout out to Carl, without whom none of this project of course would have happened.
Awesome.
Rhiannon?
Another question. So the intervention was essentially a flag that their HOMR score was beyond a threshold.
Correct.
So you classified it as HOMR positive.
So in the flag that arrived for the team, we try not to get too much into the jargon of HOMR positive, negative.
Yeah.
What is your precise mortality risk? Because that's not what we wanted people to dwell on. We wanted them to focus on, okay, this person is at elevated risk of death in the coming year. We would like you to focus on whether they have unmet palliative needs rather than getting into the nitty gritty of what your actual personal mortality risk was. Sorry,
Okay.
just to clarify.
So the emphasis was more on the action of what to perform than the score itself. So like regarding that information wouldn't have been really shared with patients themselves.
So we didn't actually tell them, and that was the point, is that we weren't trying to the point of this was it's intended as sort of what we call augmented decision making or augmented intelligence approaches. So we're nudging teams to talk to patients. At the end of the day, right? Like the computer, these are population derived models. The population doesn't know if you're ready to receive this information. The computer doesn't know if you've already had really negative interactions with the healthcare team on multiple occasions, and you're actually ready to rip someone's head off, and then this thing would come in to directly be telling you that you're dying. That would go badly, right? So our point was we're not trying to. The idea here is we're trying to nudge healthcare teams, not force healthcare teams, but nudge them, because I think in most cases it's an open door you're pushing. But we understand that in a small number of cases, the patient may be very resistant to this or unable to participate or might deeply misunderstand this, or there might be a really tense interaction already involving the team, in which case it'd be a really bad idea to kind of push them towards this, the most potentially distressing of conversations. So again, yes, to your point, there is a school of thought saying, data is democratize the data. Everyone should know what their mortality risk is. And of course, Respect and other sites have websites where you can go and calculate your own. And I can see the argument there, right? I just think in our case, we were trying to sort of be a little bit conservative, small c, at the start, to sort of try to not to have any big thing blow up where you get like patient relations and people complain. It sort of has a disproportionately negative effect on your project. I hope that makes sense.
Thanks.
Z?
Hi, James. Really cool study. I had been thinking about the default palliative care stuff from Kate Corright the entire time that you were presenting, and until you mentioned the word nudge, I wondered if I should even speak. So I was kind of wondering, beyond nudge, do you see any opportunities for mandating or automating specialist palliative care involvement?
Yeah, I mean, I don't, to be honest with you, like, big philosophical conversation, but like, I don't think that mandating palliative care is really within the realm of possible and desirable, if I can put it that way bluntly. Like, not every dying person should be seen by a specialist palliative care provider, right? There's a, I don't think we are never going to have enough palliative care providers to do that, right? To put that within the realm of possibility. I also don't think that the data suggests that it actually is all that beneficial to do that, right? Like I think, where everybody's looking now in terms of like STEP and sort of customized approaches, where you're sort of, what are the high risk populations that seem to have particularly high benefit? Because again, Miriam Johnson's paper that I love to quote from, it's almost 2 years ago now, but the number needed to treat for 6 months, so 3 to 9 months of multi-component specialized palliative care to improve one person's quality of life by one clinically meaningful amount is 15. So you have to treat 14, 15 people for 6 months to get one of them to feel meaningfully better,
right?
Just in terms of quality of life. Right. So, that's all comers. Right. So again, I think that's probably an underestimate. I think we're probably a little more effective than that, but that's what the data shows. So the idea that everybody and their dog should be getting palliative care forever, that is not only exceedingly expensive and unfeasible given the resources we're not within 3 orders of magnitude of having enough specialists to even attempt that. But I also don't think that the data shows that it would actually be all that beneficial. I can think of about 100,000. There are many, many things that would be much more effective use of our time and energy. So my thinking is, what could this do though, is there are a lot of interventions that happen in palliative world that it could drive. Right. So the most obvious being a sort of any quality improvement initiative. You're identifying a patient population prospectively to move forward with. That's the first step in any quality improvement project. And it doesn't exist for anywhere else in palliative care, right? So you having that automated thing that identifies your population to study going forward, that's a really important step. Then you can think of very scalable interventions. So like, do you have like a tablet that can do advanced care planning exercises with them, right? You just you can lower the threshold and turn that up a little bit, so more people get flagged. And you can just have somebody going around handing out a tablet to people to let them do the exercise themselves, right? So interventions that are very scalable and cheap
Yeah.
It could drive them. Deprescribing, things that could be done automatically in the computer to make deprescribing recommendations, right, for people who are entering the sort of palliative phase or like in the final year of their life,
Right.
the more palliative phase of their life, if indeed that's what they want. You can make a lot of suggestions, and patients are very, very open to that. And then, other things like, do you want frailty assessment, look at their home care needs, et cetera. Like there's lots of different things that you can potentially drive that aren't a specialist palliative care consultation that I think could meaningfully improve outcomes without, breaking the bank, as it were, in terms of resource utilization. So I'd say it's sort of, that's how I would look at it, is the real advantage here is being able to tailor your approach to a manageable population,
Sure.
and then drive very scalable interventions in an auditable way.
And James, if I might, I know that you showed a slide with connecting this data with Ontario Marginalization Index. The other thing I was thinking about is specialist palliative care as maybe a high touch, intense intervention in the hospital setting. Are there patient populations, recent immigrants, patients with limited English proficiency, where we could do a better job in using our time, our resources more wisely to manage potentially patients and family with higher unmet needs, but
yeah, I mean, if only there was a researcher looking specifically at some of these populations and some of the barriers to advanced care planning. Z, I don't know if you've ever met somebody who does that, with their research program. But I mean, you're raising the point here is that necessary. How is it necessary but not sufficient, right? So the idea that we're just nudging people, like the same way that I would take a second year, third year medical student and say, go to bed 15 and talk to, Mr. Ja about his advanced care planning. Oh, by the way, he doesn't speak English.
Right.
So you're going to translate through his granddaughter. And it's 2 a.m. That's probably not going to go well, right? Like I don't know that's going to be a very high yield conversation. It might be, but,
Right.
but I think the point you're raising here is just wanting to talk to somebody about advanced care planning doesn't actually meaningfully lead to changes in goals of care, goal concordant care, et cetera, et cetera. We don't want to make assumptions because, of course, there's no stereotyped
Sure.
value from different cultures about how they approach advanced care planning. Everyone is different, but at the same time, there are some different unique barriers in healthcare beyond simply the reluctance of people to engage in an emotional and time-consuming conversation at 2 a.m. There are things that go beyond that hold us back. So the idea behind HOMR is really just, as we push people more and more to be like, hey, I'm not asking you to talk to everybody. I'm just saying this person's probably it's the Moneyball approach. Like you're focusing your energy on potentially high yield populations.
Right.
And if you can do more, you can do more. But I think it stands absolutely to reason. And again, I don't think we'll be able to disaggregate this in our data set because some of the outcomes like ICU and intubation, those numbers are very low. So it'd be very hard to sort of, stratify according to immigrant and newcomer quintiles, for example. So 10%. That's right. Thanks, Julie, for flagging that. Because of course, we had hospitals from the GTA, including Osler, right, where you're going to see a fairly high proportion of people who are, relatively recent immigrants.
Thanks so much, James.
Thanks, Steve. Any other questions? Sorry, I go on with my answers, but just because I didn't see a lot of other hands. Yeah, no, Z, I think it's definitely something to pull apart. My thinking is because of the data that we're using, we dug deeply into individual charts for people, but I wonder if there's an opportunity here moving forward actually to do a more dedicated project for the question that you're answering here, which is to address specific, one of the core problems, and I remember I saw Serena's online. Serena helped write a section for a CD Howe paper with me on this, is that, when you look at any study of advanced care planning in North America, but particularly in Canada, it's a pretty white study. It's really white, really white. And so your ability then to look at this and sort of say, is it that non-white populations don't want to talk about this stuff? Or is it that healthcare providers don't want to approach non-white populations, or that they don't talk about this stuff because they think that they don't want to talk about this stuff? Is it projection or is it reality? And one of the things that HOMR can do is to help by having essentially a very objective approach to identifying a population moving forward. And again, it's not that big data algorithms don't sometimes fall into ethnic traps, if I can call it that, like a sort of the data a model derived in a predominantly white population might not apply perfectly well to black individuals and Asian. We have great data on this. We know this. We can't do anything about it. That's the data we have. But the idea that moving forward, you can at least have a relatively objective model to identify your population of interest that will include a good representative mix of people from all ethnicities. And then you can see, wow, we really aren't approaching these people. Like, it's just kind of crazy. And it would help you, I think, have a very objective, prospective population to identify and saying, actually, guess what? It was a lack of approach, or it was a lack of approach, and when you approached them, it actually went well. Or actually, we seem to be approaching everybody, but yeah, it actually is less well received in some populations than others. And I think there's no other way to answer that question, I think, than having a more objective approach like this.
Agreed. Thanks, James. We'd love to think about an implementation project in that sense.
Yeah. Go ahead.
Yeah, I was going to say that structure is actually sometimes really grounding. When presented with a difficult to digest topic, the emotional reaction is sometimes could be, why me, and being singled out? Am I being an immigrant or a racialized individual? But there's also a bit of safety in saying we do this to promote the best care of populations or patients from the community. So yeah, I think we could work a lot there.
I think that's true, and I think it is very reassuring to most people. Obviously, there are some who just have had really big trust issues with the system that won't respond well to that. But I think that's a recall bias problem. I think that's actually, that attitude is not very prevalent. I think it's a low prevalence, but we're very aware of it when it happens kind of attitude. I'd be really keen to work with you on that, Z.
Hey,
Okay,
can you hear me?
Hands? Yeah. Oh, sorry. Is someone on mute?
Sorry, can you guys hear me?
Yes.
Okay, sorry. See, I was just going to add, I get mixed up with the quintiles, but we did get data as well on the in ICES, the racialized and newcomer populations quintiles, and we did actually see a lot of variation in that. I get mixed up which order is 1 and 5 because they're not the same across like a bunch of these different indices.
5 is more marginalized, 1 is less marginalized. It's the inverse of the income.
Okay, yeah. So if I can give you that, so we're at about 5. So in that quintile, we're at between 25 and 30% for the racialized and newcomer populations quintile. Anyway, so we do have that. So I think there's, in addition to just the immigration status, to your point, to get to like other racialized groups as well. I think it would be interesting. And of course, the results that were presented today, as James said, are preliminary. So, we still have to do models and that kind of stuff. Everything's unadjusted right now. So, but certainly something to look at. We will be limited in some regards, just in terms of how many variables we can put in. So we've only got 2,000 patients, which is most ICES study have tens of thousands, if not hundreds of thousands of patients. But I definitely think a good place to start. And I think there's a lot that could be done here for sure.
Thanks, Julie.
Thanks, Steve. Jess?
Could you tell us a little bit more about the 8 hospitals? Did you see a variation, you think, in uptake in those hospitals, and what were the kind of successful factors? And those
so yeah, I mean, the answer is pending. So we kind of, broadly speaking, there were kind of 2 models that people would use. There's a sort of disseminated model and the champion model. So, and not to stereotype, but smaller hospitals often had a champion where you have like a team would have a nurse specialist or like a nurse on their palliative team. And that person would basically come in the morning, grab the list of admits from overnight that flagged positive on HOMR, and they just go and do it. And versus like large academic hospitals where it was more disseminated among all the staff. My intuition is that the champion model is much more effective. And HOMR, like similar to that qualitative study I told you about, like HOMR is beautifully built for a champion model. So if you have champions that are sitting through bullet rounds trying to listen for patients or listen for keywords that might think they get involved, like I'll give you back your bullet rounds hour and I'll just give you a list in the morning, you go see them. And by the time you've like not even 30 minutes, you will have already seen and assessed everybody that you probably wouldn't have even picked up had you sat through an hour of bullet rounds. So like it's a really good, strong, efficient way to sort of focus your time and attention in a champion way. But we're looking at, part of our model and our analysis is we're going to include site as a dummy variable, a site as a variable, I should say, to see if side effects were different.
Thank you.
Thanks, Jess. That's but I strongly suspect we're going to try to parse out some of the data with some of the screening numbers to see if it did seem like the ultimate outcome data seemed to be more driven by patients who got screened versus those who didn't get screened, or versus those who had screened and had high symptoms versus those who screened did not have high symptoms. Like, did it seem to be that we were responding, that these were really about a response to the people who came to our attention, or was it more of a diffuse kind of general benefit? And I think that will be the kind of thing where you want to start to feed. We have to be a bit careful because obviously with 2,000 patients, we can't have an unlimited number of variables in that model. But for some of the bigger outcomes, like where they died, for example, that we could potentially pull out. All right, it is 3 p.m. Eastern, so I would thank all of you for your kind attention and attendance. If any of you have questions or want to talk more about this, feel free to reach out, send us an email, visit the HOMR website. Thank you so much to Health Canada for supporting us and everybody else, and everyone have a wonderful day.
Thank you.
Bye, guys.